Hello and welcome to this new podcast of the American Journal of Public Health. Today, we want to explore the faith and the origin of a very important document for public health. This document was published in 1988 by the then Institute of Medicine, now the National Academy of Medicine, and it was called The Future of Public Health. And this document is considered as being a kind of watershed. It changed public health from what it was before until now. And we wanted to explore this question with Michael McGuinness, who is an executive director at the National Academies, and who will help us understand what was the importance then of the IOM and what is important today, and whether we need a new future of public health report today. So, Michael McGuinness, welcome to this podcast. Do you want to add something to the presentation?
No, thank you very much, Alfredo and Vicky, for this opportunity to chat with you about an issue that is unexceeded in its importance for the health of the nation. The only thing I'll mention is that much of my reference point will be from experience, at least at that time, in government service, as opposed to my work here at the Academies. So I do have the good fortune of having both perspectives, but I'll try to blend them as opposed to just reference work here at the Academies.
That's great. Thank you. And also on this podcast, there is my co-host, Vicky Mays, a professor at UCLA, also an associate editor with the journals. And together we prepare those podcasts, select the themes and the questions. And we are going today to have this conversation with Michael McGuinness. So, Michael, if I may, just let's do a little bit of history. Why was this report so badly needed? What was the situation of public health before 1988?
In that particular period, let's say the 1980s, we were facing a time in which the importance of infectious diseases, which had been the fundamental emphasis of public health historically, was not as well recognized. That is to say, it was overtaken to some extent by the fact that in the late 1960s, we had the passage of Medicare and Medicaid with all the funding that went into the medical establishment at that point. And in fact, a number of public health departments were becoming dominantly safety net medical care providers, which was important. Obviously, their fundamental role is to protect the health of people within a community, within a geographic area. And they also realized in the late 70s and early 80s that as interest in infectious diseases dropped off a bit as a result of the success story of public health, that funding was also a little more fragile. And so the notion that there was easy money, if you will, represented a very attractive and in some cases appropriately and in some cases too attractive source of support. Essentially, public health began to evolve from an infectious disease orientation in which the challenges were issues like smallpox and polio and childhood infectious diseases, long past, fortunately, the time of plague, but nutrition was an element that was also relevant, and with the development of WIC and food stamps and so forth, public health began to focus more attention on linking people to services that were needed across the board. And they became substantially, in many ways, a safety net and immunization and sanitation organization. At the same time, that the awareness of the importance of chronic disease that was driving a lot of those economic investments was growing substantially, but public health wasn't equipped to deal with those, wasn't equipped to deal with the new information that was developing about the importance of various behavioral choices or circumstances that drove behavioral choices, about the importance
Smoking,
of social, smoking, diet, alcohol, substance abuse.
physical activity. Yeah.
The challenge for public health was to develop a more balanced portfolio, and looking at the fact that the major causes of death in the mid to late 80s were not polio or smallpox or childhood infectious diseases. And they weren't even really where the money was going, to heart disease and cancer and stroke. They were issues around tobacco and diet and physical activity and misuse of substances and essentially a variety, a constellation of behavioral challenges, and with the overlay of social circumstances that were in fact a risk factor of their own, but they were certainly compounding risk factors and recognized as compounding risk factors for those other behavioral challenges at the time. And public health just didn't have the capacity or the knowledge, frankly, to deal with that. So the 1988 report was an important sounding of the alarm that the capacity that was most important to the health of the nation, public health and public health departments, were losing money, except for where they were able to use patchwork funding for safety net programs.
When you say funding for public health, all of a sudden I think that the 80s was also the beginning of the Reagan years. Could there have been a relationship between this new orientation of government away from public spending in order to make it go in the other direction a bit?
Well, actually, if you look at the federal budget, the budgets of the federal agencies, yes, there were assaults here and there, but they, for the most part, they continued to increase at a very modest, a much more diminished increase than they should have. And of course, that changed to some extent with the AIDS epidemic, the HIV epidemic. I remember very well. I was actually, what was it, the Hamilton places, I was in the room. Well, I was in the room when Bill Foege, who was the director of the Centers for Disease Control, came up to one of our agency head meetings and said that we had this strange cluster of 7 cases of pneumocystis carinii and Kaposi sarcoma down in the town where Vicki Mays lives in Los Angeles. And we sat around the table. This was June of 1981, trying to figure out what this was. Yeah. And of course, without going into all the details, because that's its history. And it's actually a history of a public health success story over over a relatively short period. There's never been until that time a disease which was recognized, the cause of which was the mode of transmission was identified, the causative agent was identified, the screening test was identified, and some initial treatments were identified in a very compressed period of time, basically in less than a dozen years. But it also raised awareness about the vulnerability of the nation for challenges of that sort. But the biggest problem was what happened at the state and local level in terms of the lack of the fall off of support for public health. The national consciousness just was going in a different direction. I think we have to acknowledge the fact, driven by a focus on crisis. By crisis, I mean the squeaky wheel gets the oil, and when there are emergency conditions of people having heart attacks or strokes or other kinds of challenges that require immediate medical care, there was a willingness to pay whatever it took to engage those challenges, especially when it was driven by well-heeled funding agencies, private to a substantial part. I mean, essentially, you've got a built-in mandate to, or a built-in resource to serve as a pass-through for funding of a substantial variety, and we see the profits involved in that. The challenge to public health, I think, was not only just one of funding, but really one of the mission. What is our mission?
What you're pointing out is some really important differences that started to happen. And I think you're absolutely right about what happened in terms of HIV and how, from a medical standpoint, we were able to find, interventions, but suddenly began to realize that it was really about people's behavior, about how much knowledge people had about their own vulnerability. And I'm wondering if you could talk just a little bit about how well has public health done. We can kind of see what it's done in terms of chronic diseases and medical interventions, but how well has it done since 1988 about addressing, kind of those behavioral issues, smoking, diet, tobacco?
Not well. But I don't want to blame public health. I would say that society, because those are issues that are complex with multiple social dimensions and economic dimensions. They're a lot different than giving somebody a vaccine or giving them an antibiotic. And society, it really hasn't done very well at all. It's not for lack of trying, but it's for lack of understanding what behavioral motivations are, where opportunities to change lie. The nation had used the 4 food groups basically from the turn of the century, USDA, as the major source of dietary advice, or USDA's 4 food groups, whatever. And at the time in the 70s, as a result of some of the results of the Framingham study, the NIH was identifying very real risk factors for heart disease and stroke. The fact that a lot of those risk factors had dietary associates, whether it's related to saturated fat, cholesterol, or volume of calories, made the notion of food deficiency a very outdated concept. And yet, in the early 70s, most of our nutrition activities were still focused on food deficiencies, except for a few programs at the NHLDI. One of the things I'm personally proudest of is a very small role, and that is to have a meeting called of the heads of HHS, then HEW, and of USDA, to agree that we had to do 2 things. One, we had to change our dietary counsel from food deficiency to too much food of the wrong type. And 2, we had to have a combined 2 departments to focus here. So the dietary guidelines grew out of that. And so, but despite the fact that we had dietary guidelines that were focused largely in the right direction, but with some room for misinterpretation, it's not as if we stopped the obesity epidemic in its tracks, because we didn't. The fact is that commercial enterprises and the role of media and social circumstances, which led to limited choices, despite the fact that we had a reasonable scientific set of tools, we weren't equipped as a society to deal with the other factors that were involved. So that's why public health has to be essentially the orchestra leader for a wide variety of interventions. And marshal the various aspects of society that have to be marshaled in order to change the factors that are creating ill health in society, and also provide a better sense, a better compass of where our investments are most important in changing the health of populations.
This was a very good point. I mean, of a condition for which we're worse today. But I want to also focus on things that maybe are better today, because think of the 1976 swine flu epidemic. I mean, there was a threat that looked like what COVID has been. And President Ford and CDC had decided to vaccinate the whole population. And it was a complete failure. And there was no way to really track the infections, the vaccines, their potential side effects. There was all this discussion about the Guillain-Barré syndrome. Okay, this was 76. Now we have the COVID-19 epidemic. I mean, every state have vaccinated more than half of its population. Almost every person in the country, age 65 or plus, have been vaccinated. A huge success. So between 76 and 2020 and 21, what major difference you see that would explain one failure and one success?
I'm glad you asked that question, although it's got a complicated set of answers. Obviously, there's 45 years of difference, so circumstances change in 45 years. I wouldn't necessarily say that the swine flu program was a total failure in the following sense. It did marshal a rapid response on the part of government. At least it showed that the government could respond, but it was a communication failure for sure, and frankly, it was a scientific failure. But at the time, it's easy to go back and second guess decisions at that time. One of my first jobs in government was to commission Joe Califano and Harvey Feinberg to come in and do a review of the swine flu epidemic response, because it was a big problem. But I also I think that we're also sometimes too quick to cast aspersions on people who were doing the best they could under the circumstances and sticking their necks out in a very big way. I also wouldn't say that the public health response to COVID was a great success. You know, yes, it's true that we had a very rapid response to identifying, as I mentioned earlier, with respect to HIV, to identifying the nature of the problem, the nature of the spread, the offending organization, the development of vaccine, the development of treatments in a very compressed period. I mean, it was basically not much longer than a year from one to the next. But we had also been working on that organism for about 10 years before. So the notion of the fact that we were theoretically prepared, but we still lost over 1 million people because we weren't able to mount a program that identified those who were most at risk, those who were infected, and take advantage of that knowledge. And a lot of that was because it had nothing to do with the scientific community. The scientific community was ready to go, but the political influence, the misinformation that was spread, and as a result of some leaders' propensity to take advantage of that misinformation, led us to have multiples of what we should have had in terms of casualties. I'm hopeful that we will have learned many more lessons from that experience than we learned from the first one.
I absolutely, Michael. I mean, this is all well taken. There's a lot to criticize. I just feel that in 2019, if anybody had predicted that the coverage, and this is public health mainly, the coverage of the vaccination would be that large, nobody would have believed it. And it went, just beyond any expectation we would have in 2019.
Well, yes,
maybe.
You're quite right, but I'll just mention one thing, and it has to do with communication of a different sort. As the vaccine was being developed, 24 hours a day, we saw bodies piling up in hospital hallways. And we didn't have that in the swine flu for a lot of reasons, because it wasn't a real epidemic. People were motivated, unfortunately, by fear. And in this case, it's good that they were motivated to get the vaccine. There were very few effective counter messages in that respect. Now we're dealing with it to some extent. Now that the pictures of the travesty in clinical settings are becoming faded in the memory. The biggest challenge to the nation, including to our public health community, is our ability to understand what instant communication with social media is doing, and how it can be. It's not going to go away. So the question is, how can it be channeled for good? And I'm an optimist by nature, so I'm convinced that there are ways to do that, but we're not there yet by any means. It's a bigger problem than it is a solution to almost anything at this stage, and we have to. Public health has a strong role in trying to work with others to correct that problem, and it's just another example of how public health has to be the orchestra leader, because they have to reach out and bring in the Googles and the Facebooks and the purveyors of social media in order to be effective.
Michael, let me ask another question, and that is, if you were going to write that report today, you, not a whole committee, but you, what would you say is the strength of public health right now, and what do you think needs shoring up?
I think that there needs to be less of a dichotomy between public health on the one hand and healthcare on the other. I think that we know there's going to be a lot of money flowing into healthcare. It has to be used better, and there have to be different ways of determining how it's used. Now, let me be very clear. I'm not saying that healthcare, which has all that money, via insurance and so forth, should be controlling the way our public health works. I think there needs to be entirely new structures to identify how funds flow more efficiently to the places that they're needed, and there needs to be integrated consensus structure for deciding how funds are used. Actually, back in '94, with the healthcare reform initiative of the Clintons, I actually visited all 50 states trying to holding town hall meetings in which the host in every state was actually the commissioner of health of that state. So it was both these and ours. There were no partisan politics involved. But it was very telling in a couple of ways. One is that the notion of public health, which was oriented primarily around assurance, assessment, and policy development, the fine elements, the sort of core functions of public health, was just not specific enough for people to relate to. And out of those activities grew the notion of the 10 essential services of public health, so that it became much more specific about what was needed by every community. And another was that when you looked at the way those essential services played out and had to be supported, that there had to be a means of making sure that the financing system writ large was supporting those services as well. So we actually ran a few models and had elements inserted into the legislation that had the notion of a set-aside, a small set-aside for financing funds that would go into population health kinds of activities. So there was a sustained funding source. It wasn't successful, but that's, you asked me what I would put into the report. I would say there has to be a sustained source for healthcare and public health, population health, and social services. There has to be an integrated approach to identifying through community health needs assessments that aren't run by individual hospitals, but essentially represent the whole community in identifying what's needed, and then converting what's needed into formulaic-based flow of resources into a geographic area or a catchment area of one sort, and that there be a set of metrics that are developed that every institution has to show their activities around that can be certain to drive progress. Now, what I mean by that is, right now we have thousands of measures in the health system, and most of them are just distractions. They don't really drive to the most important issues. There are ways that insurance companies can either pay or not pay for different things. There's no reason that we can't do that in a very different way, in a fashion that essentially has our investment in measures focus on things that really matter and has accountability for things that really matter. And so we've been developing at the National Academy of Medicine what we call the core principles of a learning health system. There are 10 of them. And if I was to pick a small number of those that were most important, transparency would clearly be one. We have no transparency in our health system. But if we could, we have the resources and the determination among people, if they had the information about where funds were being spent, how they were being spent, what really made a difference or what didn't, then we could call much more upon an informed public to make a difference. And I think that there's another dimension here, is that we also have another tool that's potentially coming online, and that is artificial intelligence, especially large language models and generative AI. We have the ability to force transparency in some ways about the implications of investments. I won't go into the details there. You know them as well as I do. And no one really knows enough because it's exploding in terms of the potential. But I think we have developing capacities to turn around what right now is a global embarrassment, where we spend $4 trillion for results that are rank us 40th in the world, in which the inequities that are prevalent in our system are unlike any other.
This is fascinating. And I think in your response to Vicky's question, you also pointed out to one of the limitations of the 1988 report, which is that top-down public health is not sufficient. We need to have a bottom-up public health. We need to have a participation of communities, engagement of communities. And I also think that this is one way of solving the miscommunication issue that you mentioned before.
I think that society is recognizing they can't do without it. They've recognized that in terms of healthcare, but now what we have to think about is, what do we want society to do? We know what we want the federal government to do, but as Michael brought up, some of the problems that we have are society's problems. And one of them is society's need to invest, support, demand, inquire about its public health. And Michael, I'd like to ask this as my last question. What can the National Academy of Medicine do to really highlight where public health is and what's needed in order to make it as strong, if not stronger, as a collaborative partner with healthcare?
I would underscore the fact that I think that the dichotomy between public health and healthcare, even though the activities are viewed now in two separate arenas, I think that notion is a barrier to the kind of notion that we ultimately need to have of what's important for society as a whole. So rather than a publication on the future of medical care or a publication on the future of public health, we need to have a publication on the future of health and what it's going to take for the changes to occur in the way we spend our health dollars, in the way we support our digital health infrastructure, in the way that we focus our decisions, that is focused on the needs of individuals, of people and communities, not on the needs of organizations and institutions, but on the desires and goals and outcomes for those individuals and communities, to focus on as a fundamental issue because of our poor situation vis-a-vis our neighbors in the international community, focus our first priorities on removing inequities throughout every element of the system, whether it's inequities in healthcare or inequities in the public health arena, and also take on as a basic responsibility transparency around what the implications are for private capital investments and what they mean for the health of society. As long as we compartmentalize all of these elements that play out in different ways to make us healthy or not, we're going to fail. We have to look at this system, at these system dynamics in an integrated fashion. And we in the National Academy of Medicine are committed to doing that. We've just formed a commission on investment imperatives for a healthy nation, which is looking across the board at all those issues. And hopefully we'll be able to identify in the course of this activity, along with the many thousands of people who are involved, a way to reorient our compass, to reset our moral attention in society.
This is great. Michael, I mean, your insights on the history of public health, I mean, its past, current status, and its future, that was actually the part in which I've learned the most from all our conversation, are fascinating. Thank you so much for participating in this podcast. Vicky, you had great questions. I enjoyed really enormously, as usual, listening to your questions. And we look forward to reading those new reports that you are preparing, Michael. Thank you.
Well, thanks to both of you, and thanks for your good work. Take care.
Thank you, Michael.
Thank you.